Good morning, everyone. Thank you for joining us this morning. Those of you who are online and the audience here with us. I am Dr. Vasha Bachan. It's my pleasure to be moderating this session with you this morning. It's also my pleasure to be introducing our speaker to you, Dr. P Strosser. He's a psychotherapist who has worked in a variety of settings within the mental health field for over 15 years, including residential facilities, schools, outpatient clinics, university counseling centers, and he's now in private practice since 2020. He is skilled at working with people from diverse backgrounds and utilizes an integrative therapeutic approach with evidence-based treatments and modalities. Dr. Strosser has traveled to Guyana several times in the last year and continues to adapt and utilize his expertise in psychology while learning about the unique culture of Guyana to support the Guyanese with their mental health. So this morning, he'll be talking to us about the vicarious traumatization, implications for mental health providers, and the resilience model. So Dr. Strosser, thanks for being here with us, and the floor is all yours.
Thank you, Dr. Bachan. Good morning, everybody. Welcome. All right, I'm gonna go ahead and share my screen. Let's see here. If you all just can let me know if that shows up for you. Is that good? I'll go ahead and we'll get started. All right. So yes, I'll be talking about vicarious traumatization and implications on mental health providers and a resiliency model. Just as a note, like was mentioned, I work in mental health and I have for many years, but what I will be talking about can really apply to anybody that is in the helping profession. So whether you're like a first responder or work in a hospital setting, really any helping profession, this can be helpful. So let's get started. So where we are going. So we're going to go over some definitions to get started, because I always find it helpful, just because like when you do research and look in literature, sometimes there's just different definitions for similar terms, things of that nature. And especially some of the things that I'm going to be talking about, there's a lot of like overlap. So I just want us to kind of all be on the same page as we move through. So we'll go through the definitions of primary and secondary trauma, and then talk about secondary traumatic stress, and then compassion fatigue, and then that'll move us into and give us a good foundation to talk about the compassion fatigue resiliency model. And there's 3 separate sections that'll be broken down, and there's actually like a visual that we'll go through that'll, I think, will be helpful. And we'll go over the empathic stance and the different variables associated with that. Then we'll go over the secondary traumatic stress variables. And then finally, and where I really would like to spend some time, is the compassion fatigue resilience variables. And those are the things that are going to help and hopefully give you some actual like real world techniques to kind of help in whether you're in practice with mental health, or if you work in, again, like a medical setting, or just really involved with anybody that has experienced any type of trauma. And then we'll save some time, hopefully, for some questions. And the other thing is, I'm pretty easygoing when it comes to the presentation. So if anybody has like a question along the way, if you just want to put it in the chat, or if I know there's people there in person, Dr. Bachan, if you can always like pause me and say, hey, someone has a question, or can you clarify? I'm happy to do that. All right, so here we go. So primary trauma. So trauma comes from the Greek word trauma, which is just meaning wound. And again, that can mean both physical and mental wounds. So when an event takes place to you as an individual, that is traumatizing. That's what we're talking about with a primary trauma. So it's what is actually happening to you. You've actually experienced it. So I, just as a brief overview, I tend to separate them into 2 different types: natural versus unintentional interpersonal. So the first one is kind of obvious, just natural disasters like hurricanes or earthquakes, things of that nature. And then others would be like work-related accidents and car accidents, and that would fall under more of the category of unintentional interpersonal. That is, if it's considered like a car accident, the whole idea about accidents, the person probably didn't intentionally try to hit you, but it still involves another person. So there's still that human interaction that led to the traumatic experience. And then the second one that I like to separate is intentional interpersonal. So that can be along the lines of physical abuse, attempted sexual assault, completed sexual assault, things of that nature. Um, and again, I think those can have a different impact just because it's a human to human. It makes us question just like humanity and the world, and if the world is safe, which can have lasting effects, not only the trauma survivor, but it can also have an impact on us, which we'll get to as the person who might be working with them. So, all right. Secondary trauma. So helping those who are in need is the first part, and then having who have experienced a primary trauma. So again, someone that has gone through a car accident, or someone who recently had a physical assault, something of those along those lines. But it's us as the person who is meeting with them and interacting with them. So we're not directly involved with the traumatic experience that they had. What this requires, and we'll get into a little bit more detail later on, is empathy. The ability to actually, understand and what it would be like to actually have gone through that. That has, I put like gift and cost, because it's a gift to be able to, I usually will say, like, sit in the mud with people to hear their experiences. But as we will come to find out, that can be a gift to that person, but that comes at a cost because it requires a part of us. Um, so some of the similar terms that you'll find like in the literature, I won't use. I'll pretty much stick with like secondary trauma, but some of the terms that you'll find are like vicarious traumatization, secondhand trauma, helper's burden. But what I really just want you to keep in mind and remember is secondary trauma. This is the precursor to what is known as secondary traumatic stress, or STS. So, and I think throughout the PowerPoint, I put in the shorthand of it, but I think I spell them out, so I don't expect you to remember that, because I'm still don't always remember them all either. So, all right. So next is secondary traumatic stress. So what is that? So I think the best way, this is a little bit of a kind of making it a little bit simplified, but I think it's what makes the most sense, and I think serves the purpose of what I'm trying to communicate during this presentation. And that is PTSD is to primary trauma as STS, that is secondary traumatic stress, is to secondary trauma. So so you have a secondary trauma, and that can lead to, not always, just like in if you're familiar with post-traumatic stress disorder, just because someone has a traumatic event does not necessarily mean that they will also have post-traumatic stress disorder or meet the criteria for that. It all depends on the person and a lot of other variables. Same with this. But I think that's just to give kind of a foundation for that. So what it can look like, though, and things that you can start to pay attention to is just like, and this comes from PTSD, the intrusive memories. So like remembering what has happened. So in this case, it would be like remembering what the person told you. Avoidance. So like trying to avoid, maybe you're just avoiding like work, or going to work because of where the last thing that you heard from somebody you were working with. Negative changes in thinking and mood. So your mood might be down. You might just think like, oh, the world is this awful place. People are awful because of the things that you've heard. And then changes in physical and emotional reactions. So just maybe a little bit more emotional reactive. Maybe you get just upset more easily because of the things you heard. And again, this is not because you experienced the traumatic experience, the traumatic event. It's because you listened to somebody to it. Or I'll give an example of like even like first responders, like you showed up and you see someone that was in a car accident, you see what has happened to them. Again, you didn't witness it, but you're now experiencing the aftermath of it. So the terms secondary traumatic stress, STS, is sometimes used interchangeably um, with the term compassion fatigue, which is what we're going to talk about next. And that's usually STS is used more broadly in different professions and disciplines. So, all right. So compassion fatigue. It usually involves emotional and physical exhaustion and decrease in ability to empathize, which is one of the things that I think one of the main reasons we are paying attention to it and it's important is because it can lead us to not being able to perform. And again, in my profession as a mental health professional, like it can lead to me not being actually able to do my job and do my job effectively, and can actually, in extreme cases, can actually lead to harm to the person that we're trying to help. So I think it's not only part of this conversation is just bringing awareness to it, because right, we can't really change anything until we become aware. And then next is once we are aware of it, identifying what we might be struggling with, and then we'll get into some of the things that can be helpful. But the term compassion fatigue has really come out a lot in the literature and research, and he's used a lot in like the helping professions, especially like mental health. How am I doing? You guys with me? I usually do better when I have feedback, but I recognize this is online / like hybrid. So um, again, just stop me if you have questions. And again, we'll have time for questions at the end too. So compassion fatigue resilience model. This is, just to be clear, this is not something I came up with. This was developed by Ludick and Figley. And just to let you know, I adapted this. It's still the same model. I just changed the colors just so it can differentiate, because it's usually just in black and white. And I think this just will make it clearer for just the explanation. So just take a look at that. You don't need to memorize all that. It'll come up several times as we move through the presentation, but just to give you an idea of just the visual, because I know some people are a little bit more visual, myself included. So, all right. So empathic stance variables. So when it comes to dealing with like the whole idea here, in order to have an issue, so to speak, with or even to get to the STS, you have to have an empathic response, right? You have to actually sit with somebody. So for that to happen, that's where the idea of exposure to suffering comes in. So you have to be exposed to it, right? You actually have to sit down and talk with somebody, or if you're in a hospital setting, like you're actually working with someone who has gone through a traumatic event or has come in after being sexually assaulted, something along those lines. So you first need to have that. The next is the empathic ability. And with that, empathic ability is like innate to us as humans. We all have some capacity. Now that capacity differs. So usually I would say there's probably some room for like improvement on that, but usually it's something that like some of us just have more of than others. Um, but what is important about that is so it's the actual like emotional connection that you have with somebody. So it's that idea of, I don't know if anybody has ever heard of the whole idea of like actually empathy is like actually putting yourself in that person's shoes, or putting yourself in that person's actual experience, and like visualizing that being there, and then allowing the emotions to kind of flow up so that you can have a better understanding of what they're going through. So this is needed in order to treat and work with people. But again, it puts us at risk, as mentioned before, this puts us at risk for STS. So that's just something to keep in mind. And then empathic concern is the idea of it's having compassion and interest and wanting to help somebody. So it's the actual like, so I have an ability to sit with people, but then I actually have this motivation to like, I'm going to actually like move into that space deliberately and sit with someone. Um, and a lot of this comes from just us as humans. We have this desire to be connected, right? That's why we have like communities. That's why we get together in groups. Um, and we want to be understood. Like I think at our deepest levels, we really want to be understood and loved and cared about. That's what we want ideally as humans. That is not something that always happens, and not always something that happens for a lot of people in our world. Um, so the other thing I just want to kind of mention, like, so mostly, so as mentioned, like I'm from the U.S. I know I'm talking to a group that lives in Guyana, and also I know there's people from around the world. So a lot of things that I am talking about and some of the things I am mentioning is obviously in the context of like the U.S. So just keep that in mind. I have been to Guyana a few times and have a little bit idea of culture, still learning and growing in that. Um, but just, just want to put that as like a caveat. Like I'm still growing and learning in that. So if I say something, you're like, well, that doesn't really fit for my context. First off, apologize and trying to cover as broadly as I can. Um, I think the other thing I just want to mention is more like a personal thought with the empathic concern is just this idea of I think it's what we want. Like if I went through like a traumatic experience or I was hurt, like I wouldn't want somebody to sit with me, listen and understand what I went through. Like that would be meaningful to me. So I think it's something that we all want. I don't think that a lot of people have the opportunity to experience that, but I think that's that's part of what we look for as humans, and especially as like a mental health provider, that is something that I at least try to provide when working with people, and especially individuals, especially like trauma survivors. So all that to say, put those all together, you have the empathic response. Okay, so you need to have that. So where does that put us into? That puts us into the STS variables. So first, you have to have the empathic response, and then that can lead to again. So let's say if you're doing that well, someone's going to feel understood, validated, be like, oh, they get it. That's awesome. And again, that can be helpful, and especially in the mental health work and the therapy that I do, right? Just being understood and believed, that can be healing in and of itself. However, there's the other side, which is what we're getting to, is how that impacts us. And um, this, this is I guess, the crux or like the important part and kind of our next stepping off point. So, um, first, you have to have the empathic response. Well, I guess first you have to have the trauma. If we didn't have trauma, then I wouldn't need to be having this presentation. So, we have the empathic response, then we have the secondary traumatic stress, and what can impact that and can increase the likelihood of you developing the secondary traumatic stress. Again, remember, similar to PTSD, one is prolonged exposure to suffering. So again, over here you have the exposure to suffering, and then this is just like, think of it like a dose. If you ever heard like a dose response, it's this idea of like over time, the more and more you're exposed to, the more it can increase and build up, so to speak. So, and especially if you're working like independently and you have a high caseload, or like even in like the ER or something along those lines, like it's just one after the next like person. It's so many people that can just add up over time. The next important part is traumatic memories. So this is two different parts, but the first one is fairly straightforward in the sense of it could be your own trauma history. So if you had any type of, even just something like a car accident, or it maybe is something more longer term, like prolonged childhood abuse or something along those lines. Now, there's mixed results in the research, and by that I mean they'll say it can provide a level of empathy, right? If you've gone through something similar to someone else, you, in a way, you're able to empathize at a different level because you have an idea, not the same, but you have an idea of what that actually looks like. However, it's like a double-edged sword in the sense that if you haven't processed through it, if you haven't, what we would say in like trauma therapy and that work is like if it hasn't been integrated and anytime and you're still having flashbacks, you're still having avoidance of situations and you get triggered, and if you're getting triggered by the person that you're sitting in front of, you become dysregulated, they become dysregulated, and we're no longer doing work. We're no longer helping. Um, Especially in my profession, like that's something that, we're trying to provide a space that is grounded, safe. But if myself as the therapist is dysregulated, not able to stay with them, that's going to make it very challenging, if not detrimental, to actually doing the work that they're coming in to do. So again, it can be helpful. It's more if you've gone through and done the work and you've integrated what has happened to you, then you can have the empathic understanding, more like you can be like, oh, I know what that's like, but not have the emotion dysregulation. You can still feel it, but not getting thrown off, so to speak. And then traumatic memories, so they also, in this model, Ludic and Figley mentioned how it can actually be like the memories from previous cases, like previous people that you've worked at, also fits into this category as well, of like you could be remembering, or you could be sitting with someone and maybe there was a time that you were with a client or with a patient and it reminds you of one that really, really hit you hard and never really had the time to process through it. That could come in and impact you and contribute to the secondary traumatic stress. And then the last one up in the corner there is just other demands. This is just life stuff, right? Like, I mean, you got bills, right? You got bills due, you got family, people get sick, right? We've all been going through the pandemic. I don't know. I say to my patients nowadays, I'm like, that we're kind of in it, we're kind of not in it. I'm not really sure where we are, but like that, those are things that just we have to deal with in life, and those have the potential, because of the strenuousness of working with trauma survivors, those can be amplified and kind of set us off more so that than it would typically. Um, so again, just another factor that contributes to that. All right. Any questions? All right, go on to the next. All right. So this is where I'm hoping to spend a little bit more time and try to go in a little bit more detail. So these are the compassion, fatigue, resilience variables. And we're going to go through each one of these a little bit more detail, but they include self-care, detachment, sense of satisfaction, and social support. So let's get started. And I'm going to take a drink of my coffee because my throat is dry. All right, this is the model we saw at the beginning, right? So hopefully, if I am articulating things well, this is starting to make sense and come together. And this no longer just looks like a bunch of arrows with a bunch of shapes, right? So we have trauma, something that has happened. You have the empathic response, which has the three components to it. This can contribute to secondary traumatic stress, along with the three things that we just went over: prolonged exposure to suffering, traumatic memories, and other demands. And if we just stop there, that would be sad, because then we'd be like, well, okay, you've told me what I'm dealing with, right? And if I just ended the presentation, you'd be like, well, that's not really helpful, other than I know what's going on, but I'm just here. So that's not what we're going to do. What we're going to do is talk about how you can both proactively and reactively, I guess is the best way, because I want to also take into consideration, like, we all probably are in depending what profession you're in, like you're probably in it, right? You're dealing with patients, you're dealing with clients. If you're in the helping profession, you're working with people, and you might already be experiencing this. It's not like you are coming in with probably like a blank slate and going like, oh, I can just prep for this and prevent this all from happening. You're more likely in it. So the idea here is to go through some things that hopefully you can start doing and put into practice. And then honestly, my biggest goal is for you to take some of this away and start putting into practice, and then just to share it with other people. Because the idea here is I'm only one person, and I have found this helpful in my own practice. But one of the reasons that I like to uh, do presentations and communicate with people is like to spread the word um, is the best way to describe it, because it can not only be helpful for us as providers, people that are in the helping profession, but right in turn that helps and I think directly contributes to helping the people that we're privileged to serve. So here we go. So self-care, I'm just going to go with the definition in the literature. Self-care is defined as the learned behavior of practice and activities initiated and performed by individuals to maintain health, life, and well-being. All right. So, right, I think, so I'm going to go with sometimes I think self-care can be, some of this just comes from my own like personal experience, but I'm also talking from like a American context, just to clarify. This idea of self-care is like, oh, it's all about me. I just take care me, especially, and I'm generalizing for the Americans here, own that, of like, oh, it's very, we're very individualistic. It's all about myself and what do I need to do for me. That's not what self-care is. That's not, and I think sometimes it can get, I guess, it can get a bad rap of like, well, I can't focus on myself. Well, how many people, okay, this is going to be one of those moments I ask for a little bit of feedback, or if I can just get like a thumbs up in the chat or something. See if I can see the chat. Hang on. Sorry, did I just take away? Give me one sec, everybody. I can't find the menu. Oh, there it is. Okay, how many, if you guys can just put in the chat, how many people have flown on a plane before? Can I just get like a thumbs up, even just one person? Okay, good. Thank you. I see it on the thing. So, and when you're on the plane, I'm sorry, we're gonna jump back through there. When you're on the plane, who do they tell you to put the mask on first? You can either say it or, oh, hi, Latoya. I just saw one of my friends. Okay, yes, yourself. Yes. Margaret, why does anyone know why yourself? Anybody? It's okay. I realize this is a hybrid situation. Yes, can help. Can help yourself. Can help if you are not well. Yes, exactly. So the idea here is, if I'm unconscious, like, right, let's say you have like a kid, right? Like, oh, I want to make sure I take care of my kid first. Yeah, that's not going to be helpful. I'm going to be a little sarcastic right now. That's not going to be helpful if you're not breathing, right? Like literally, like that to us as humans, like that makes sense. Like you put your mask on first so you can keep breathing, because even if that person goes unconscious, you are more likely to be able to help them if you're breathing. You could, whatever you need to do, get the mask on them, resuscitate, whatever. Maybe I know that's a little extreme, but like the idea here is, again, you need to take care of yourself. And I think as helping professionals, I think, and again, I'm speaking from my US based education. I think we do a lot of talking about self care. I mean, we do a lot of talking about self care. It's like on the rage. The follow through, and again, this is my personal experience. It, the follow through is not so great, and by that I mean like the way things are set up, the way that whether it's programs, caseloads, et cetera, it's not set up for that. So in some ways, it's something that you have to be intentional about, and you have to work at. I think that um, we can all help. Like if we each start to kind of come up with our own like self-care and work on that, then we can start to create more of a culture for that, so to speak, right? If we all just keep going along with it, which like in grad school, that's definitely what I did. It's like, oh no, it's okay. I need to stay up and do all this work and see all these clients and do all these things. But it's not really sustainable. So some of the options, I just want to give some practical um, ideas, and maybe you've heard of these, or maybe you're like, I have no idea what those even are. Um, you can always look up self-care options, but what I think I really want to get across here is it doesn't need to be something that takes up a lot of time. It's not something that needs to take up a lot of money or resources. What it really is about, I think the best word is like consistency. It's about doing something on a regular basis to take care of yourself that you know is helpful. So I think one of the simplest ones, and probably one of the most, I guess, basic, is just deep breathing. I'll go through a real quick, because maybe some of you know this, maybe some of you don't. With deep breathing, the way that I have learned, and the way that I usually teach it to patients and clients that I work with, is you breathe in through the nose, out through the mouth. But the important part is you do a shorter in breath and a longer out breath, because what that does is it engages what's known, the fancy term is your parasympathetic nervous system. For all the medical providers, you're like, oh yeah, cool. For those of us that didn't go to for medicine, what that basically is just your rest and digest. So it's just basically telling your body, like physiologically, okay, we're gonna settle down now. We're gonna calm down by doing the shorter in and longer out. And then the other thing I usually say is to count. So count in and count out. Because what that does is it gives you something to focus on. So you're focused on your breath, and it's also giving your mind something to do in that moment. And what that can do is you're not focused on what's about to happen, and you're not focused on what already did happen. You're here in the moment, which can be a very grounding experience. And the reason for this is if you're dealing with individuals um, that have experienced trauma survivors, in any context, that can be dysregulating in a lot of ways. So this can just be something in the moment that can help you. So this is something I do just in my own work, and it might not even be that when I'm working with someone that has trauma, it just might be a long day, or I'm just tired from seeing 7 or 8 clients in a row, something like that. It just gives me a moment just to settle, give my brain a break, give my body a break, and then be able to return. Again, it doesn't take away the stress or the work that I have to do necessarily, but again, it can just settle you. And it's more, again, we're back to the consistency. Doing that over time and on a regular basis can help with the self-care. The other thing is like going for a walk, listening to music. There's all kinds of things. It's really something that is relaxing to you. So it's not about, oh, this is the best one. It's really about finding what works for you and relaxes you and brings you to the here and now. Like scrolling on your phone and things with technology, this is again personal opinion, I would be hesitant with that because it's not really bringing you to the here and now um, necessarily. So the last part about self-care that I think is important is self-compassion. So this is a definition, or I should say not definition, it's a quote from Newsom. So kindness and understanding towards oneself instead of being harsh and self-critical. Oftentimes, those working with traumatized individuals have more compassion for others than they have for themselves. Um, I think that the reason I put that in there is because I think self-care is not about always like what we're like doing, like the deep breathing or physically going for a walk. I think it's also what we say to ourselves. I know from myself personally, like when I've worked with people, um, especially when early on in my career working with trauma survivors, I did a lot of things that were not helpful. Did I learn from them? Yeah, I did. And did my clients teach me? A lot, probably a lot more than I learned in books. Um, and I think it was easy for me to be harsh on myself. And some of the research says, like, us as helping professionals, especially in mental health, we can be really critical of ourselves, which is not helpful in a lot of ways. So I think it's about, right, if when I'm sitting with someone, I'm having empathy and compassion for their experience. And like I said before, like that's what we all want from other people. And in some ways, I think we also need to give that to ourselves, and just to recognize, like, hey, like you're putting in the effort, you're doing the work, you showed up. Did you do it perfectly? No, you're never going to do it perfectly. I've come to that realization many times, and that doesn't need to be the expectation. Um, so I think just having self-compassion is something to really, I think, just start to pay attention to. Like, pay attention to like what you're saying to yourself, especially in those moments of when you make mistakes, but even just on a daily basis. I had a colleague when I was out at University Counseling Center in Texas, and he would get up and just say, I think, like 10 kind things about himself in the morning, just because it was helpful. He's like, I need to remind myself of the good in the horrors in the world. So that is self-care. How are we doing time-wise? 36. All right. Let me next slide. Okay. Detachment. So with detachment, definition is psychological detachment as the off-the-job action of switching off mentally and not being occupied physically or mentally by work-related matters, aka how do you leave work at work? Um, let's just say, right, the pandemic did not help with this at all. When the pandemic hit for me, I was on internship, and we went from being fully, obviously, in person to fully online. Separation was already not a good thing. At that time, I was working a lot, and it became worse because my office became a living room. So, detachment is, everybody has different abilities to detach. Some of that can be related to some of the variables that we talked about before. Um, and it can also be things that were like modeled to you, like growing up, like parents and um, other like figures in your life that modeled, like, were they able to separate? But I think especially for us as like healthcare providers, mental health providers, it it really is something that we need to pay attention to. Of what do we do? Are we taking work home? And I don't even necessarily mean physically taking work home, because I know we probably all have done that. Slash, sometimes that is just what's required in order to maintain our jobs, right? Some of that's just, I want to be respectful. Some of that's just the reality. If you want to still have your job, like, you're going to have to do that. So I don't want to make light of that in that sense. The other aspect, though, that we're really talking about here is like mentally. And I say this specifically for those of us that work with trauma survivors, that when someone gets done, uh, telling you a traumatic experience, especially when it comes to that, what we mentioned before, that intentional interpersonal trauma, that can stick with you. And I know that from personal experience, and it's really hard to detach from, because it's the empathy part. It really, I want to be able to do something but the reality is, like, it's already happened. I can't do it. I can't do anything about that. So I can choose to either continue to focus on it, or I can continue to acknowledge, okay, it's there, but let me move on to something else. Because the idea here is going, lack of better words, like ruminating on it, or like just going over and over, like, the story. That doesn't actually, it definitely doesn't help me as a clinician, unless, like, I'm conceptualizing, but that's different than ruminating and just going over and over it. it also definitely doesn't help the client, right? One, it takes away from your energy, but like you're not actually doing anything. I don't know if you've ever heard the expression of with anxiety. Anxiety is like sitting in a rocking chair. It's something to do, but it doesn't get you anywhere. Like if you're trying to go from point A to point B, you're not going to go in a rocking chair, right? You're just going back and forth. Same idea with this is when you don't detach and you're just like thinking and thinking and thinking, that's not actually, you're not really accomplishing anything. If anything, it's pulling you down and leading you probably more into that direction of the stress of the STS. So some of this again is just ability. Like some people, I have colleagues and peers that they are just they're for lack of better words, I think they're just really blessed with nope, this is what I talked about here, and when I leave work, I'm I'm done. Like I shut it off, and that's what has allowed them to do it for decades, and that's great. I've had to work probably a little bit harder, or at least from what they have when I've had conversations with them. So some of that, a lot of, or actually say some of that, a lot of that has come from training and experience and the ongoing self-care that I say is impacted by. So I think it's definitely something that you can work on. Um, like for me, what I'll do is, especially if I've done, like if I'm working with a trauma survivor and like I do an intake, like I usually will try to finish up that note and then I'll be like, okay, note done, or at least most of the verbal vomit is on the page. I close it and it's like that will still be there. It's not going anywhere. I'm gonna leave it there. And it's about being intentional. It's kind of like mindfulness, being intentional, be like, okay, I acknowledge that that's still there. There's still work to be done, but right now I'm gonna go do something else and making that conscious choice. Again, easy to talk about, harder in practice, but again, it can be practiced. So, all right, and then sense of satisfaction. Um, so the best way that I think, so one, the way they describe it in the literature, Conrad and Keller put it, a sense of fulfillment from helping others unequivocally, um, or sorry, this is the quote from them. A sense of fulfillment from helping others unequivocally mitigates compassion fatigue in protection workers. So that they did a research study and they found that when they actually had a sense of fulfillment, like they actually saw like, oh, I'm actually helping these kids. Like there's actually like I'm getting them out of an abusive situation. I'm getting them into therapy. I'm getting them help. I'm getting maybe they are going to get reintegrated with the family with support. When they have this sense of like, oh, this is helping, it really gets the even hearing the trauma that does not impact and it barely impacts them because they're like, oh, it's this sense of hope, right? It's like, oh, wait, what I'm doing, even though I'm having to sit with this, what I'm doing is helping. And I'm seeing progress, right? It's us as humans, like when we become hopeless, that's where this can lead to like what am I doing? Like why? Like it seems futile almost, right? But when you have this sense of like, oh no, wait, this is happening, um, or this is helping. It it really can be like a protective factor. So one of the things I put there is for number one, like progress and planting the seed. So um, part of what I think can be difficult is, and I know that this is just something personally that I have to work on as like a clinician is um, working. So I work collaboratively with clients, but I also like I want to help, right? I want to journey with them and I want them to achieve the goals that they're wanting to achieve. So we usually are lined up about goals. However, timeline wise might be a little bit different. Like I want them to, right? I'm like, let's go, let's do the work. I'm here, you're here, let's go. But motivation for them might be a little bit different. So I think it's attenuating that drive of wanting to help and reminding ourselves and looking for the progress. Um, and I want to be careful, not, I don't use the term little to minimize, but like looking for the little progress, looking for the little steps that are taken. Like for example, like maybe someone's coming in with severe like depression and they just haven't been getting out of bed and their goal is to get a job. Well, after a few weeks, maybe they're finally like getting out of bed like 2 times a week and maybe they're finally researching They still don't have a job, but that's progress. And I think sometimes it can be hard to miss. And I know this is for me personally, like, oh, we're not here yet, but it's like, let's not forget where we were and how far we've come. And that's why I put the idea of strength there as well is let's what has changed, what has been working. And not only do I find that very helpful for clients, because sometimes clients, especially clients that deal with like depression and also traumatized individuals that have experienced trauma, is this idea of like, oh, I haven't made any progress. And it's like, okay, hang on. Let's talk, let's explore where we were or where you were. Use we because usually it's more collaborative. Let's look where we were when we first started. Let's look at where we are now. And usually when you paint that picture, it's like, oh wait, okay, I'm not where I want to be. Okay, but have you made progress? Yeah, I've made progress. That can also be by doing that, that also helps me to keep in mind. Again, it's not in a sense it's I want to be careful because it's right, it's for the client, but it has this extra effect of like, oh wait, we are doing something, we are making progress, and it's that I think that for me it brings that sense of satisfaction of like, no, we are doing something, like we're moving towards the goal, we're not stuck and we're not going back, so we're moving forward, and that's the idea, and that's something to keep in mind. All right, last is social support. um, So, a research study that was done stated that quantitative data whereby therapists explain how social support and a sense of connectedness fulfilled, sustained, and shielded them from trauma exposure, exhaustion. Um, Social support is like I just love social support. Um, and it's also hard to come by, especially with the pandemic. However, it's just a huge protective factor. That's what it is. Not only in this research that I've done um, in this like literature review, but like in I've done for my directed study for my doc program, I did research with veterans, and one of the major protective factors for veterans against PTSD is social support, because what I think social support and healthy social support, I guess I should clarify, and this is kind of my personal thought, is right, if you're dealing with people who have gone through some of the most horrific things imaginable, trauma survivors, it can you can become pretty cynical, especially if you're just working with individuals like that solely. It's helpful to have people you are that love and care about you and are not doing those things, for lack of better words, is opposite, because it reminds you of like, oh wait, this isn't the whole world of what I'm sitting with the people that I'm privileged to work with. There is another side. There is hope, and that I think we need in order to sustain the work long term. Again, I want to be um, I can't think of the word. I want to be cognizant of like not everybody has that opportunity. I've been very blessed that I have a great relationship with my Julie, my wife. I have great social support, just like with friends and also with family. So that has allowed me to do the work that I get to do, and I know that, and I am also intentional with those relationships. But I also recognize not everybody has those opportunities, or those opportunities are much harder to come by. So I just want to be respectful of that. Of like, I don't want to say like, oh, just go get it. It's so easy. It's not always, especially where you are. And I will also say, um, it professionally, social support is helpful. When I was out on internship out in Texas, we had a trauma supervision group. And again, I think sometimes if you might not have it naturally, the social support, but you can create it. You can try to find people that have similar thoughts of like, hey, like we need to support each other. We need to like have conversations. That's what our trauma supervision group was about, was we had trauma, we work with trauma survivors, unfortunately, a lot more than I would ever expect at a university. But that was the reality. And it was it was such a relief. We have it, I think it was almost once a week, where we'd come together and just be able to not only talk about cases and conceptualize and be like, hey, this is what I'm doing, this is what I'm not doing, but it'd also be a time like, how are you doing? Like, how are you feeling like with what you heard and like what you talked about? Like, how is that impacting you? Like, where's your empathy levels, right? Like, where is your, without saying it specifically, like, what is your STS? Like, where's that at? Where's your compassion fatigue? Um, and just getting that support was so uplifting and provided so much hope. So that's something to also consider. And with that, there is the model from start to finish. And yeah, questions? We have 10 minutes.
Dude, thank you, Dr. Strosser. Thanks so much for your presentation. I'd like to invite any comments or questions from the audience here, as well as those online. We can go through the chat and see if anyone has welcome. We have some questions from the audience here, Dr. Strosser.
Yeah, recently there has been a lot of talk on chronic fatigue syndrome in workplace. How does that differ than compassionate fatigue syndrome?
Can you say, sorry, I just didn't get, what was the syndrome?
Chronic fatigue syndrome.
Chronic fatigue syndrome. I'm not familiar with that. Is it that?
Especially in the working environment.
So I'm not just hearing the term. It sounds familiar to what we're talking about. I'm not sure how it differs. I would actually have to look at like the definition of what it is.
Workplace, they overwork and they don't have time to exercise, they don't have time, right? To eat the right food. Right? It's
Sorry.
in the work environment. It's in the work environment.
Oh, so just in the work environment. Just you mean so not even working with necessarily like trauma survivors or people that have experienced trauma, just the work environment, the stressors of the work environment. Is that what you're saying?
Yeah.
Yeah, I would say how does it relate? I gotta think about that for a second. I would say there's probably some overlap. That would probably fall more. I've done a little bit of like research and more review of the research just in like burnout, and I think that probably falls a little bit more into the area of burnout. That is right, like just the ongoing stressors of the day-to-day routine, or maybe like interpersonal conflict between like coworkers, things of that nature. But that would probably be more related to burnout, which again, I think there can be a lot of overlap between what we talked about today, burnout, the chronic fatigue, which you're mentioning. But I would have to do a little bit more. I'm just not as familiar, so I'd have to actually look at the research on that.
I personally think it's overlapping.
Sorry, what? It's just a little bit muffled. Can you say that one more time?
I'm saying that the compassionate syndrome, right, is overlapping with the chronic fatigue syndrome.
Yeah. So yeah, the compassion fatigue. So compassion fatigue is I guess more specific to like the actual like helping profession. So if you're actually working like in like human services, so you're directly working with people and you're helping people. That's what that relates to. Whereas the secondary traumatic stress, that's more broad, but that's also related to still working with individuals that have experienced traumatic events.
So there
I'm not
is a
sure.
little difference in between the two. Great. Any other questions? Yes, please go ahead.
Before you were in private practice and you worked in an organization, how did your organization help? What systems did they put in place to help decrease vicarious trauma? What's that?
Yeah, so that's a good question. So my first job, well, so I started way back. I started like direct care staff, so like working like one-on-one with clients at a residential, and then I moved in. earned a master's degree, came back as a master's level therapist, and that was at the same residential program. And what I do think they did provide is we had like weekly team meetings, and then we also had daily check-ins with us as staff and us as the residents, or sorry, the residents that we worked with. But more to your question, by us being able to check in with our staff each day was get an idea. Okay, like, and it was in between shift. Sorry, it was between shift changes. So it was coming in saying, hey, what's been working well today? What hasn't been working well today? And it also gave us the time to be like, hey, how's your day going? What's going on with you? Like more that um, part of that model, the part of the model with the outside demands. It's like, hey, are you sick today? Like, did you have any stressors with your family? They did. I think they did try to build like camaraderie. They'd also do like different events to help us build a relationship because especially at the residential facility, because a lot of the I worked with adolescent boys and there was some of them could be like very aggressive and like there was risk and danger there. So you had to really depend on one another. So I think they did a good job of doing like team building exercises and just feeling like you could go to one another and talk. And then the team meetings um, each week were helpful because you come in and be like, hey, this is what's working, this is what's not working. This person has really been stressing me out, and like they told me about this that happened. Um, and you know, can we process that? That was a lot for me to handle. So I think as they did a fairly good job at the residential facility with all things considered. And then when I've worked in, so I've done a lot of like outpatient work, and some of that is a part of like, so when you're in training, there is just with supervision, like both group supervision and individual supervision, that provides a lot more support than you would typically receive in like private practice or other organizations. That's when you start to get into like private practice or even like other organizations, some of that is not as built in, and sometimes it is depending on the place. And if it's not, that's then where I would recommend like trying to create it, so to speak, which can be hard. Does that help answer?
Thank you.
Mm-hmm.
Any other questions from the audience? Dr. Strosser, in cases of individuals who are more, I would want to see, you know, as we call them introverts, how does social support work for them?
That's a good question. I think it's because even I think as like I think it's about finding the areas in which you thrive. So I think it goes back to like even with like the self-care stuff, it's finding what works for you. So even if you're more introverted, like I still would say people still have they still want to have relationships. Because like I have friends that like are introverted and you know obviously like I'm friends with them, so like I think it's not about the quantity. I would say it's more about the quality. So I would say someone that's introverted, just having even like one person like a close friend that they can spend time with, or even less like a coworker that they get along with and relate to and have like similar hobbies or things like that, or is also introverted and they enjoy doing things online or something like that. It's more about just having someone to have community with, and not the number. But again, I think with the social support, right, it's going back to reminding yourself that there's hope. There's people that are good. There's people that are that can like uplift you, so to speak. Does that answer your question?
Somewhat, because as you mentioned just now, if like those particular individuals are trying to build relationships, especially if it's like online or so, I'm just thinking about the, I want to say quality of those type of relationships. You know, are they really good for them? Are they more long lasting, or would they still benefit more from like a more interpersonal, meaning I would want to say more face-to-face sort of interaction with other peers in their group.
Yeah, I would, and this is probably more of an opinion. I think I would actually have to look at the research, which I am just not as familiar with, but like, just like personal experiences and especially work with a lot of like teens and stuff. Just the like, right, because the pandemic has put us in this we were already moving into this like whole online and like just pulling away from like face to face. I still I still go back with the idea of sitting down face to face with someone in person is still the best because there's something about us as humans that when we're in a room with somebody, there's just a connection that happens. And can you get some of that via video? Is video like way better than just like phone or like text? Absolutely, because you can see and right, it's much more of a real-time interaction. I still my stance is like being actually in person one to one again, like especially for therapy work, I still think is the best. Again, can I still be effective online and do I do online therapy? Absolutely, because I think it's still helpful. But ideally being in person, I think us as humans, right, we're called to community, and community, by community I mean like actually interacting with one another. Because I think long term slash I think what we've seen from the pandemic is we've had a lack of that, and I think it's causing a lot of challenges uh like socially and like social, especially like social anxiety, things of that nature.
Thank you, Dr. Strasser.
Absolutely.
And thanks for taking the time to answer our questions. We're
Yeah.
just a little bit over time, but I want to thank those online who joined us and
Yes.
those who were here in the room with us. If we can just give Dr. Strasser a round of applause for his presentation.
Thank you, everybody. Thank you for coming. And yeah, hope you have a great rest of your day. Y'all take care.
Thank you. You too, Dr. Strasser. Thanks, everyone.
Bye.